Fragmentation of the medial coronoid process is the most common cause of forelimb lameness in the dog and a major contributor to elbow osteoarthritis. This problem is often referred to as a FCP or a FMCP. Most dogs are in the developmental stage of their life when clinical signs develop. Some dog breeds are highly predisposed, while others are statistically protected from developing a FCP. Swiss and Bernese Mountain Dogs are the two breeds with the greatest predisposition. Male dogs are also slightly more predisposed to this condition than female dogs. The clinical signs associated with the FCP are from inflammation and pain in the elbow joint. Owners may report that the dog has lameness, a swelling over the elbow joint, or is reluctant to go downstairs. The exact etiology of FCP is unknown, but given the high frequency in certain breeds, it likely can be a heritable trait. Current evidence would suggest that genetics, mechanical overloading, and a diminished capacity to remodel dead or damaged bone contribute to a multifactorial etiology. It is important to be aware that more than one component of elbow dysplasia may be present in a patient. Scientific reports suggest a fragmented medial coronoid process can be seen concurrently with osteochondrosis dissecans or with an ununited anchineal process. Physical exam findings may include lameness in one or both front legs. Some dogs have an obvious swelling on the lateral aspect of the joint, and there will be pain on flexion, extension, or external rotation of the elbow. I tend to find pain in extension early in the disease process and pain in flexion late in the disease process. Many dogs with end-stage elbow arthritis stand with the carpus on the affected side externally rotated. Some dogs develop an abnormal posture because of elbow pain. This is a photograph of a dog that has a FCP in the right elbow. Notice how the unaffected left leg is pointed straight and the affected right leg is pointed laterally. This is easiest seen at the carpus. Confirm that this asymmetry is a consistent finding before concluding that it is abnormal. This is a video of a dog that has a right forelimb lameness secondary to pain in the right elbow from a FCP. Notice how the head drops every time the unaffected left foot is placed on the ground. This is an excellent example that supports the saying, down on sound. During the orthopedic examination, it is important to localize pain to the elbow joint. This dog has pain on flexion of the elbow joint. Some people have difficulty distinguishing between pain in the elbow and shoulder. Isolating pain to the elbow can be achieved by flexing the elbow without flexing the shoulder. In this video, I do this by stabilizing the shoulder in a neutral position with my left hand, stabilizing the radius and ulna with my right hand, and then flexing the elbow by bringing the carpus to the point of the shoulder. In this video, I isolate flexion in the shoulder joint by stabilizing the scapula with my left hand. I stabilize the elbow in a neutral position with my right hand, and then I flex the shoulder joint by bringing the olecranon to the caudal point of the scapula. Several diagnostic tests can be used to help confirm the presence of FCP. Arthrocentesis of the elbow and cytology of the synovial fluid would only provide evidence of inflammation. Several different radiographic views have been described for the elbow, including a flexed lateral, extended lateral, craniocaudal, and oblique views. Computed tomography, or CT, provides far more accuracy than plain radiographs when trying to identify a specific cause for elbow pain. CT also has the advantage that both elbows can be imaged at the same time. This is commonly performed because fragmentation of the medial coronoid process has a high incidence of affecting dogs bilaterally. Currently, MRI is the most accurate diagnostic tool, and in advanced centers, special MRI techniques can be used to estimate proteoglycan or glycosaminoglycan content in the cartilage of the elbow. Finally, surgical confirmation of the disease is available. While plain radiographs are commonly performed, they may not identify a FCP if it is early in the disease process or if the medial coronoid process is not displaced. I would suggest that it is reasonable to make a diagnosis of a FCP if there is evidence of osteoarthritis on an elbow radiograph, the dog is of a breed that is highly predisposed for FCP, and the dog has elbow pain on physical examination. An extended or flexed medial to lateral radiographic view can be made to identify an osteophyte on the anconeal process or the presence of subchondral sclerosis in the ulna. These are general abnormal findings and are not associated with any specific elbow disease. More specific radiographic abnormalities include a step between the radius and ulna or the presence of a blunted medial coronoid process. However, I would caution those that only occasionally review elbow radiographs not to overinterpret subtle findings, as they may not be pathology, but simply be a deviation from normal that is not clinically relevant. A cranial to caudal radiographic view is generally the most useful to identify a fragmented coronoid process. On the two images presented, a slightly displaced FCP is identified with an arrow. A 45-degree cranial lateral to caudomedial radiograph is sometimes made so the medial coronoid process is in a better tangent with the primary radiographic beam with less superimposition of other bone. Computed tomography has greater accuracy than radiographs at detecting a fragmented coronoid process. It can also identify abnormal bone pathology in a non-displaced, diseased medial coronoid process. Finally, ex vivo research has demonstrated that CT has improved sensitivity at detecting abnormal steps or incongruity between the radius and ulna. On these two CT images, you can assess the appearance of a normal medial coronoid process on the left and a non-displaced, diseased medial coronoid process on the right. These images demonstrate delayed gadolinium-enhanced MRI of cartilage or degemeric. MRI techniques like degemeric and T2 mapping estimate the proteoglycan or GAG content of the cartilage and have been used as an outcome measure in some clinical investigations because it has been demonstrated that a poor biologic cartilage score is associated with a poorer clinical prognosis. These methods are also a more precise way to monitor the progression of arthritis.